go ahead and get started. We've given a few extra minutes for the stragglers to come in, which is nice. This is Melanie Pickett, Dr. Melanie Pickett. She's just finished up her dissertation. Dove. You have a recent name change.
Oh, lots of changes.
All right, well, congratulations. Is that a marriage?
Yes.
Okay, all right, wonderful. So Melanie Duff is here today. She's just finishing up her doctorate at Harvard. I believe just submitted her dissertation, defended it a couple of weeks ago. Is now on the interview circuit, and one of her options is to come here to UCI to work with me, so I'm very excited to have her here today. And she's going to be giving her talk on smoke-free air laws, secondhand smoke exposure in health in children and adults. And I will add, actually, Melanie was an undergraduate here at UCI some years ago in the School of Social Ecology. And so it's nice to have you back here. I guess that was in environmental analysis and design, yeah, which I believe is social ecology, right?
It was.
It was. Yeah, there's been some restructuring recently. So one time, though, social ecology.
Yes.
And of course, our MPH program actually grew really out of the School of Social Ecology, and a lot of our senior faculty are from that area. So it's kind of nice to have an old student kind of return after many years with Doctor and hear what she's been doing since then.
Thank you.
Yeah.
So it's nice to be back here and to be able to present my research, so thank you for this opportunity. Today I'll be talking about smoke-free air laws, secondhand smoke exposure in health in children and adolescents. So this is just a brief outline of my talk. First I'll give a little bit of background on exposure to secondhand smoke and smoke-free air laws. Next I'll describe my 3 papers, and for each paper the methods, results, conclusions, and how it compares to other studies. Then I'll describe the strengths and limitations together for all 3 studies, and finally I'll give an overall conclusion. So please feel free to interrupt me if you have any questions. So secondhand smoke exposure is both the smoke exhaled from smokers, called mainstream smoke, and the smoke produced by the burning end of a cigarette, called side stream smoke. And it has over 250 toxic chemicals, which 60 are known as suspected to cause cancer. And some of them are listed here, including arsenic, benzene, beryllium, and others. Secondhand smoke causes a number of health outcomes. In 2006, the Surgeon General's report evaluated all the evidence and concluded that secondhand smoke, there's sufficient evidence that secondhand smoke in adults causes coronary artery disease, lung cancer, and reproductive effects in women. And in children, there was sufficient evidence that secondhand smoke causes middle ear disease, respiratory symptoms, impaired lung function, SIDS, lower respiratory illnesses, and low birth weight. So a useful way to measure secondhand smoke exposure in non-smokers is to use cotinine, which is a metabolite of nicotine, and the half-life is about 15 to 20 hours. This is a figure showing the distribution of cotinine in the U.S. population. And so on the x-axis is serum cotinine levels on the log scale. And so cotinine has a bimodal distribution, so that non-smokers over here tend to have cotinine levels less than 10 to 15, whereas smokers tend to have cotinine levels greater than 10 to 15 nanograms per milliliter. So the strengths of using cotinine as a biomarker of exposure to secondhand smoke are that it can be measured in a variety of mediums, including serum, saliva, urine, hair, and toenails. It's specific to secondhand smoke exposure in non-smokers. And the half-life is longer than nicotine. Nicotine's half-life is about half an hour to 3 hours. There are some limitations with using cotinine. It reflects exposure within the past couple of days. There's been shown to be diurnal variations with cotinine levels higher later in the day. And reflects exposure to nicotine, which isn't the most harmful chemical in secondhand smoke. This is a graph using data from the US showing that cotinine levels have decreased over the years. And so they were first measured in 1988, and this is geometric mean cotinine levels. So they've decreased quite dramatically over the years. And this figure shows is just for children aged 4 to 16, and it's stratified by whether or not they lived with a smoker. So the red line shows that among children that lived with a smoker, there was no change in geometric mean cotinine levels over time. However, the yellow line is children who did not live with a smoker, showing that cotinine levels decreased from 0.12 to 0.05, suggesting that there's something in the environment that is contributing to this decrease. So smoke-free air laws completely ban smoking, and they're primarily enacted in indoor areas such as workplaces, restaurants, and bars. And they've been increasing over the years. This is a map of the U.S. in 2000 showing that only 2 states had a smoke-free air law, including California and Utah, and a couple of local laws in California and also in Massachusetts. But by 2005, there were 10 states with a smoke-free air law. And by 2010, there was 34 states covering 74.2% of the U.S. population. So smoke-free air laws, there's been many studies that have shown that smoke-free air laws reduce secondhand smoke exposure in adults. And they've also been shown to change social norms towards smoking, reduce smoking prevalence, and increase the number of smoke-free homes. So these things combined may result in a reduction of secondhand smoke exposure in the community that would result in children being less exposed to secondhand smoke. And in children, there's been few studies that have looked at this association. There was one study in Scotland that looked at cotinine levels in children before and after a smoking ban, and they found a 39% reduction in saliva cotinine levels. And a study in Wales attempted to replicate what the Scottish study found, and they found a 12% reduction in cotinine. So there's been a lot of studies looking at the impact smoke-free air laws have on heart attacks or acute myocardial infarction in adults. And this is a meta-analysis that came out recently that looked at 11 studies, primarily in the US and Europe. And they found a pooled rate ratio of 0.81, suggesting a 19% reduction in AMI hospitalization rates after a smoking ban compared to before a smoking ban. And a similar meta-analysis came out around the same time, and they found a pooled rate ratio of 0.92, suggesting a 8% reduction in AMI. So both these meta-analyses looked at the impact of the smoke-free air law over time. And so on the x-axis is the duration post-ordinance. This one is in months, and this one is in years. And on the y-axis is the log of the rate ratio. So as the time increases, the rate ratio increases. So the impact of the Massachusetts smoke-free air law on AMI has not been examined until now. And Massachusetts has a long history of tobacco control. In 1993, they formed a tobacco control program. In 1994, the first smoke-free air law was implemented in Amherst. In 93, 96, and 2002, there was an increase in the Massachusetts cigarette sales tax. In And in 2003, Boston implemented a smoke-free air law, and about a year later, the state implemented a statewide smoke-free air law. So my overall hypothesis is that smoke-free air laws lower secondhand smoke exposure and thus reduce disease in both children and adolescents. So the first paper is called Smoke-Free Air Laws and Secondhand Smoke Exposure Among Non-Smoking Youth in Haynes 99 to 2006. These are my co-authors. So the study population is the National Health and Nutrition Examination Survey, also called NHANES, from 99 until 2006. This is a cross-sectional survey. It's representative of the US population. It uses a complex multi-stage design. There's home interviews and also physical exams in these mobile examination clinics. And there were 117 survey locations or counties sampled between 1999 and 2006. So this describes the complex survey design a little bit better. So first, counties are selected, and then segments or city blocks are selected, and then households, and finally individuals. So the study population included youth aged 3 to 19 years who are not missing data on codeine. We limited our analysis to non-smokers, defined by both having a codeine level less than 15, and also by we excluded youth who had smoked in the past 5 days, and we had a sample size of 11,486.
Do you want questions now or at the end?
Yeah, no, it's fine.
So I presume secondhand smoke still has an effect on smokers, so why would you exclude smokers?
So we're looking at non-smokers. We're looking at kids. So, right, secondhand smoke does have an impact on smokers, but we want to see the impact of the smoke-free air law on non-smokers. So if we included smokers, we're looking at codeine levels.
Right.
And so most of their codeine levels would be from them smoking. And smoke-free air laws are primarily enacted to reduce secondhand smoke exposure. And so it would be difficult to see the impact of the smoke-free air law because although smoke-free air laws have been shown to reduce smoking prevalence, that's not what they were
Right,
designed
so the magnitude of the effect wouldn't be
It would be
detectable given the huge base rate of codeine.
right. So right, there's large, they've seen really large decreases in codeine among non-smokers as a result of these smoke-free air laws.
And that's in urine or toenails? What?
Serum.
Serum.
So our exposure is smoke-free air law coverage. So in-Haynes survey locations or counties were put into these 3 categories. 26 counties were classified as having extensive coverage, meaning there was at least one smoke-free workplace, restaurant, or bar law at the county or state level. 11 counties were classified as having limited coverage, meaning there was at least one city within the county with a smoke-free workplace, restaurant, or bar law. And 80 counties were classified as having no coverage, meaning there was no smoke-free air laws coverage at the state, county, or city level. And this tree outlines the exposure a little bit more. So we identified which county each individual was in. Then we found out if they had a state law, and if they did, they were classified as having extensive coverage. If there was no state law, but there was a county law that covered the entire county population, they were classified as having extensive coverage. If there was no county law, but a city law, they were classified as having limited coverage. And no city law, they were classified as having no coverage. So our outcome is cotinine. And from 1999 until 2006, the limit of detection was lowered. So from 1999 until 2000, the limit of detection was 0.05. But in 2001 to 2002, the limit of detection was lowered to 0.015. So 15% of the sample had the higher limit of detection, and 85% had the lower limit of detection. And from 2003 to 2006, everyone had the lower limit of detection. And in Haynes, for values that are below the limit of detection, and Haynes imputes a value, that's the limit of detection divided by the square root of 2. So it's 0.035 for 0.05 and 0.011 for 0.015.
About what percentage of your study population actually had levels below the limit of detection? Is that a large percentage or a relatively small fraction?
Right, so there was about 45% that had levels below 0.05 and about 17% that had levels below 0.015. So the lower limit of detection gives us a lot more data to work with. So we looked at cotinine two different ways. The first was dichotomous, using all of the data from 99 to 2006. And we looked at cotinine levels greater than or equal to 0.05 or less than 0.05. And we used prevalence. And for the years 2003 to 2006, in which everyone had the lower limit of detection, we looked at cotinine continuously, and we naturally log transformed cotinine, and we looked at geometric means. We use SAS and Sudan software to analyze the data, and the Sudan software takes into account the unequal probability of selection and non-response, the multi-stage design, and the correlation among sample persons within clusters. For dichotomous cotinine, we looked at prevalence ratios because the outcome was greater than 10%. And for continuous cotinine, we looked at the ratio of geometric means. We adjusted for the following covariates. In Model 1, we adjusted for age, race, gender, survey cycle, ratio of family income to poverty, region of the country, and number of meals eaten outside the home, which is a proxy for amount of time spent in a restaurant. And we also, so we adjusted for these variables in Model 1. And in Model 2, we additionally adjusted for adult smoking prevalence. And adult smoking prevalence may be acting as a confounder in that it's associated with smoke-free air laws and cotinine. However, it might also be acting as an intermediate variable, so it's on the pathway between smoke-free air law and cotinine, in which case we wouldn't want to adjust for it. And so we look at it both ways. We also looked at effect modification by home secondhand smoke exposure status, and this was assessed by if at least one person smoked inside the home, all members were classified as having home secondhand smoke exposure. So these are some of our results. This is looking at prevalence ratios by among all non-smoking youth and stratified by home secondhand smoke exposure. So the prevalence ratio comparing extensive to no law coverage was 0.59 in Model 1, and after additionally adjusting for smoking, adult smoking prevalence, it attenuated to 0.70. And among children from non-smoking homes, the association was stronger. The prevalence ratio was 0.51, which attenuated to 0.61. And in Model 2, there was no difference between the limited and the no law coverage categories. And among smoking homes, children from smoking homes, there was the prevalence ratio was 0.97 in both models, so indicating no association for extensive or limited coverage categories. And this is the distribution of codeine on the natural log scale by smoke-free air law coverage. So this is using data from 2003 to 2006. So on the left-hand side are children from non-smoking homes, and the right-hand side, children from smoking homes. And so the dark black line is at codeine at 0.05, so you can kind of see the distribution of those above and below this cut point. And the dotted line are the geometric means. So among children from non-smoking homes, going from extensive to no law coverage, the distribution moves towards higher codeine levels. However, among children from smoking homes, there's very little difference in the distribution of codeine by the 3 smoke-free air law coverage groups. So these are results looking at the ratio of geometric means among all non-smoking youth. There's a ratio of 0.47, comparing the extensive to the no law coverage, which attenuated to 0.58. Amongst children from non-smoking homes, the ratio of geometric means was 0.50, which attenuated to 0.57. And again, we find no difference between the limited and the no law coverage categories. And no difference looking at children from smoking homes, comparing the extensive or limited to the no law coverage category. So in conclusion, among youth not exposed to secondhand smoke in the home, there was a 39% lower prevalence of detectable codeine and a 43% lower geometric mean, and no difference between the limited and no law coverage categories. Among youth exposed to secondhand smoke in the home, there was no association between smoke-free air law coverage and codeine. So this figure just shows how our results compared to the Scottish study. And so our results are labeled in Haynes. So the Scottish study also looked at children stratified by whether or not they lived with a smoker. And so among children as a whole, we found similar results, as well as stratified by having a smoker in the home. So our second paper was called Smoke-Free Air Laws and Asthma Prevalence, Symptoms and Severity Among Non-Smoking Youth. And again, these are our co-authors. So our study population was very similar. It used data from Haynes again, from 1999 to 2006. We looked at children aged 3 to 15 years, non-smokers, again, defined by codeine, and youth who had not smoked in the past 5 days. And our sample size was 8,800 because we looked at children aged 3 to 15 instead of 3 to 19. Our exposure, again, was exposure to smoke-free air laws, and we combined the no and limited law coverage categories into the category no smoke-free law coverage in the county versus having a smoke-free air law.
For the age, why did you choose 15?
Right, because a lot of the covariates that we wanted to adjust for were only collected until the age of 15. So we thought it would be better to limit it to 3 to 15 instead of 3 to 19. So we were able to look at a number of different outcomes. So we looked at prevalent asthma using 2 different definitions. The first was self-reported current asthma. So youth who responded positively to both, has a doctor or other health professional ever told you you have asthma, and do you still have asthma, were classified as having self-reported current asthma. And we looked at the second definition called ever asthma plus current symptoms. So if youth responded positively to this first question, and they had at least one of these following symptoms: persistent wheeze, chronic night cough, or wheeze medication use, they were classified as having ever asthma plus current symptoms. We also looked at asthmatic symptoms alone. So if you had at least one of these symptoms, they were classified as having asthmatic symptoms. We looked at persistent ear infection and asthma severity by having an asthma attack in the past year or an emergency room visit for asthma. Again, we used SAS and Sudan software to analyze the data. And we looked at effect modification by home secondhand smoke exposure and age. So we looked at the following covariates. So in this column, we looked at some of the same covariates as in the previous analysis: age, gender, race, ratio of family income to poverty, to service cycle and region. And in this column, we looked at some additional covariates that have been found to be associated with asthma. So household size, health insurance, BMI, mother's age of birth, mother smoked during pregnancy, low birth weight, and ever attend daycare or preschool. These are some of our results. And so the odds ratios on the y-axis. And so for prevalent asthma, using the definition of self-reported current asthma, we found an odds ratio of 1.08, indicating no association. However, looking at ever asthma plus current symptoms, we found an odds ratio of 0.74, indicating a reduced odds of having ever asthma plus current symptoms if you have a coverage of a smoke-free airlock. And looking at asthmatic symptoms total, so having at least one of these symptoms, we found an odds ratio of 0.67, and similar odds ratios looking at the symptoms individually. And for ear infection, we found an odds ratio of 1.01, suggesting no association. This figure looks at odds ratios for asthma attack and ER visit for asthma. And we found similar odds ratios of 0.66 and 0.55. This figure looks at the association between smoke-free airlock coverage and ever asthma plus current symptoms and asthmatic symptoms stratified by home secondhand smoke exposure. And so for ever asthma plus current symptoms, it looks like there might be a stronger association among children who do not live with a smoker. However, the p-value for the interaction term was 0.36. And for asthmatic symptoms, it looks like there's no difference in the association between smoke-free air laws and asthmatic symptoms, whether or not you live with a smoker. And this is a similar figure stratified by age. And so for both outcomes, it looks like there might be a stronger association among children aged 5 to 12 years of age.
That might reflect the prevalence of asthma by age. Most asthma gets diagnosed at around 5.
Right.
And then typically it would resolve around teenage years.
Right.
So that in terms of the number of people aged 5 to 12 that might be likely to report having asthma.
Right. Right. We do get into smaller sample sizes. Yeah. So in conclusion, smoke-free air laws primarily reduce the symptoms associated with asthma, but not the prevalence. And we found odds ratios of 0.67, 0.66, and 0.55 for asthmatic symptoms, asthma attack, and ER visit for asthma respectively.
Did you compare the odds of the clinical outcomes comparing children that live with smokers versus children that don't live with smokers? I mean, ideally, you would hypothesize anyways that there would be a stronger effect there than the pre-post among the pre-post law among the children that don't live with smokers.
Right, right. I did look at that. And I'm remembering the association between children who do live with secondhand smoke exposure and current asthma, and it was similar. There was no association. But for the symptoms, there was an association between, among kids who lived with a smoker had more asthmatic symptoms than kids who did not live with a smoker. So there's only been one other study that has looked at the impact of smoke-free air laws on children's health impacts in children, and this was a study conducted in Kentucky that looked at emergency room visits for asthma before and after the implementation of the smoke-free air law. And they found a 18% reduction, and we found a 45% lower odds of going to the ER for asthma in a county with a smoke-free air law compared to a county without a smoke-free air law. And since there hadn't been a lot of studies looking at this association, this figure looks at studies that have looked at the association between secondhand smoke exposure and these health outcomes. So for persistent wheeze, the Surgeon General's report found a pooled odds ratio of 1.26. And a previous enhanced study that looked at similar outcomes found an odds ratio of 1.3 comparing high cotinine levels to low cotinine levels, and 1.1 comparing medium cotinine levels to low. And our odds ratio is 1.72. And this is a similar figure, but looking at prevalent asthma. So the Surgeon General's report found an odds ratio of 1.23, and the previous enhanced study found odds ratios of 1.5 and 1.1. And our study found an odds ratio of 0.93 looking at current asthma and 1.35 looking at ever asthma plus current symptoms. So the last paper looks at it's called The Impact of Massachusetts Smoke-Free Workplace Laws on Acute Myocardial Infarction Deaths. These are co-authors. So this paper looks at a different data set. Looks at Massachusetts adults aged 35 years and older. And there are 351 cities and towns in Massachusetts. And before Massachusetts implemented a state law, 61 cities that already implemented a very similar law, which is about 25% of the population. So we were able to look at data from 1999 until 2006, and Boston implemented a smoking ban in 2003, and about a year later, Massachusetts implemented a smoking ban on July 5th, 2004. So our exposure was exposure to the Massachusetts state smoke-free air law, which bans smoking in all enclosed public places and workplaces, including restaurants and bars. And there were some exceptions to this law, and they're just listed here, including private residences, hotel rooms, tobacco stores, and others. The outcome was death from acute myocardial infarction. We used primary cause ICD-10 code I-21. This was obtained from a registry of death certificates, and it was recorded as the number of deaths per day per town. We had 4 questions that we wanted to look at with this data set, and so we used Poisson regression models. And the first question was we wanted to know the overall impact of this state law. So we used an indicator variable for the state law, and we looked at it among Massachusetts as a whole, and by age, gender, and whether or not you had a prior smoking ban. Secondly, we wanted to see if there was an impact of the local laws. So we restricted the population to just those towns that had implemented a local law and time before the state law. And we used an indicator variable, again, for the local law. Next, we wanted to see if there was an interaction between the state law and a prior local law. So our hypothesis was that among towns that had already implemented a local ban, there would be no impact of the state law, but among towns that had not implemented a local law, there would be an impact of the state law. And finally, we wanted to look at the impact of the state law over time. So we adjusted for the following covariates: linear term for time, season using annual and semi-annual sine and cosine terms, ambient PM 2.5, weekly number of influenza cases, city and town specific demographic characteristics obtained from the census listed here, a random intercept for each city, and the population, age 35 or greater, was included as an offset in the Poisson model. So this figure shows time on the x-axis and the number of people covered by a smoke-free air law in Massachusetts on the y-axis. And so in 1999, there were very few people covered by a local smoking ban. And then after Boston implemented their smoking ban, this number increased. And it increased a little bit more, and this is when the state law was implemented. It increased even more.
Question on that?
Yeah.
Do I see 2 months before the state law there were big increases, or is that just that you, or is it really that the month of the state law implementation in June 2004 you had this humongous jump? Or are there some data points months before there where you see the large jumps too?
Right here?
No, keep going. Yeah, no.
The
Immediately, what's the first month in which you see the slope go through the roof?
Oh, it's July 2005.
It is the first, so there's no lead. in
No,
terms- okay.
no,
Just one.
this is just the state law,
Great.
because everyone
Okay.
was covered
Just
here.
one.
I think that's just to connect the dots.
Yeah.
That's what I
Yeah.
figured, but I wanted to be
The
sure.
line,
Okay.
So this shows on the left y-axis the AMI mortality rate per 100,000, and so the pink line is the observed AMI mortality rate, and the black line is the predicted AMI mortality rate using data before the state law and adjusted for time and season. And so about a year after the state law, the observed rates look to be below the predicted rates. So this table shows the AMI mortality rates in total. So we had about 3.3 million people, and we had an adjusted 7.4% decrease in AMI mortality after the ban compared to before the ban. And we found no significant difference by age or gender. However, when we looked at prior local smoking ban status, we found that there was a decrease of 9.9% among towns that had not implemented a local ban, and no decrease among towns that had already implemented a local ban, similar to the state law.
I'm not sure everyone will know why there are those peaks and valleys in the previous slide.
So AMI has a seasonal pattern with rates greater in the winter than in the summer, and so that's why there's these peaks and valleys.
Why is it greater than winter?
Right.
Do we know?
I'm not quite sure. I think it may be because there's more flu cases, more respiratory illnesses in the winter, or
Shoveling snow.
shoveling snow. Yeah.
We are in Massachusetts.
Yeah. So it's,
So that begs the question whether you see the same peaks in
Yeah.
California.
You see a seasonal pattern, but not.
Not as strong.
So next we looked at the impact of the local laws. So again, we restricted the population to towns with the local law and towns before the state law. And we found the AMI mortality rate decreased by 4.9%, comparing the rates after the local law to before the law. But this was not statistically significant. The p-value is 0.32. And this looks at the interaction between the state and the local laws. So this interaction term was statistically significant. And so, among towns that had implemented a state law, there was no difference, or had implemented a local law, there was no difference in AMI mortality rates after the state law. But among towns that had not implemented a local law, there was a 9.2% decrease in AMI mortality after the state law compared to before the state law. And this chart looks at time on the x-axis and the cumulative sum of the difference between the predicted and the observed on the y-axis. And so the dark gray line looks at towns that had not implemented a local smoking ban. So it hovers around 0, meaning there's no difference between the observed and predicted, until here the state law, there's a little decrease and then a sharper decline about a year after the state law. And the lighter colored line looks at is towns that had implemented a local smoking ban between May 2003 and June 2004. So this is when most of the local bans are implemented. And it also hovers around 0 until the Boston law was implemented here. And about 8 months later, there was a decline, and then sort of a parallel decline here after the state law.
So you would expect that 8 months later, those two lines will converge, because it took Boston about 8 months to.
At some point, right, they'll
Yeah.
flatten out, maybe follow up longer.
If you follow up, I suppose. It just seems longer
Yeah,
than it took Boston to have that effect.
right. Right, and then we have, I think 2007 data is now available that we can look at to see, if the trends continue in this decrease or if they flatten out.
Unless, of course, it implies that in places where the laws were forced by the state, maybe compliance isn't all that.
Yeah, I think
Right.
Bill's question gets at a larger point of what are the carrots and the sticks of local versus state laws? I mean, what's the strength of the Boston law versus the Massachusetts law? Is there any way that we can think of? I mean, you've done a great job at kind of separating them out and interacting them. Do we have any idea of
What compliance?
the
is
teeth?
what-
Yeah, how much does it cost for a bar? If they violate it, is it thousands of dollars? Is it $100? Is there some legal ramifications?
Right, I'm not quite sure about the penalties. I think maybe at first there was a warning, and then if you did it again, you got fined. But I think for the difference between the state and the local laws, for local laws, such as one that was implemented in Boston, at the time, you could smoke in bars and restaurants in Cambridge, which is just across the river. It's like less than 3 miles away. And so if you wanted to smoke at a bar or restaurant, you could just go to a different city. Whereas if you implemented the state law, then it's much different to go to another state. Or much more difficult to go to another state.
Yeah.
So. And so we looked at the impact over time using the Poisson regression models as well. And so 0 to 12 months after the state law, there was a 1.6% decrease. And 12 months after the state law, there was an 18.6% decrease. So in conclusion, there was an overall 7.4% decrease in AMI mortality rates after the state smoke-free air law compared to before the law. Among towns without a local smoking ban, there was a 9.9% decrease, and steeper reductions were seen 1 year after the state law. So prior to the state law, about 25% of the population was covered by a local smoking ban. Local bans were associated with a 4.9% decrease in AMI mortality, and the state smoke-free workplace law did not further reduce AMI mortality in these towns. So this table compares our results, labeled MA, to a similar study conducted in New York. And among the 11 or so studies that have looked at this association, ours was most similar to the New York study in geography, in time, as well as in New York, they had implemented a lot of local county smoke-free air laws before they implemented their state law. However, a big difference is we looked at AMI mortality, and New York looked at AMI hospitalizations. But we saw a 7.4% decrease, and New York saw an 8% decrease.
Jump back just 2 slides. Yeah, that guy. I mean, the statements are technically accurate, but they kind of lead you to believe that this is attributable mainly to the smoking status or smoking law. But you saw that the overall marginal effect was a decrease in mortality associated, anyways, right, with time as you were going along. So do you have just the attributable effect that you would estimate, and which would be basically what your model would have assumed pre-post the law?
I think I calculated, it's in a backup slide, I can try to find it.
That's okay. I am interpreting that correctly, though, right? This is including both the temporal trend in mortality as well as the change in the law.
Right, but we do adjust for the temporal trend in mortality. So we include a term for time that adjusts for a linear downward trend in AMI mortality. So we do adjust for that downward trend.
In these figures.
And these are all adjusted figures,
Okay.
yeah. So now I'll talk a little bit about the strengths and limitations. First I'll talk about the Indians data. And so some strengths were, or first I'll talk about the limitations. There's potential misclassification of smoke-free air law coverage. So someone might live in a county with a law but visit a county without a law. Or a child may live in a county without a law, but individual places may have implemented their own laws that we wouldn't have detected. There could be misclassification of current asthma status. It was based on self-report and not validated with medical records. The cross-sectional survey, so examining the timing of events can be tricky. And there could be residual confounding. We didn't have information on parental asthma status, which is a strong risk factor for children's asthma. Some strengths were we had a large sample size. We had an objective measure of secondhand smoke exposure among non-smokers at Coatney. We were able to look at Coatney 2 different ways, both dichotomous and continuous, and we found similar outcomes. And we were able to examine a number of respiratory outcomes. For the Massachusetts study, some limitations include, again, there could be misclassification of the local smoking bans, as I just mentioned. There could be inaccuracies in using death certificates as a measure of death from AMI. We did not account for the changing population over time, so we used the same population, the 2000 census population from 99 to 2006. We did not have information on individual smoking history. Some strengths are that it was a large data set. We were able to adjust for many potential confounders. And we were able to compare towns with and without a local smoking ban. So our overall conclusions are, in children and adolescents from non-smoking homes, there was an association between smoke-free air laws and decreased exposure to secondhand smoke as measured by serum Coatney. Among children from smoking homes, there was no association between smoke-free air laws and Coatney. And combined, we saw an association between smoke-free air laws and decreased asthmatic symptoms. And in adults, we found an association between the Massachusetts state smoke-free air law and reduced AMI mortality rate and a larger impact 1 year after the ban. And we found a smaller association between local smoke-free air laws and a reduced AMI mortality rate. And these are some contributors that helped greatly to this research, to my research committee. We collaborated with the Massachusetts Department of Public Health, the National Center for Health Statistics, and other Harvard School of Public Health faculty. So thank you.
I have a couple. First, it was excellent presentation. 2 questions. So I'm thinking of other state or county level factors that could influence smoking levels but not be caused by the law, that might coincide with the law. So one example is prices of cigarettes. So we know that changing the state tax on cigarettes can dramatically change consumption. Do you know anything about kind of the concurrence of state laws, or perhaps state laws with cigarette taxes, or with general educational efforts that seem to kind of be mustered with this state law? And if so, is there any way you can try to control for that?
Right, we did look at the impact of cigarette sales tax. So in 2003, I think, Massachusetts increased the cigarette sales tax. And I looked at how that impacted cigarette consumption. And so there was a sharp decrease in cigarette consumption right after the Massachusetts cigarette sales tax, but then it kind of plateaued. And so it didn't impact. So at the time of the state law, it was in that plateau.
Okay. So it preceded it a little bit.
It preceded it,
Okay.
yeah.
Second question is kind of what an economist would ask, and I'm not an economist, but it's, you seem to convincingly show that there is a reduction in secondhand smoke exposure among children in non-smoking homes. So, which leads to the conclusion that smokers are smoking less in these areas that previously were not banned, but now they're banned. Well, given what we know about addiction and smoking behaviors, it makes me think, well, where are they going to smoke then? Because maybe their overall smoking levels are being reduced. Or maybe they're just smoking somewhere else. So they
Right.
could smoke in another city, like you mentioned, or they could
Right.
smoke at home.
Right.
And so you have this interaction effect of smoking homes and non-smoking homes, and you found that in smoking homes, we didn't see codeine going down among the children.
Right.
And what I've seen in some of the economics literature is, in fact, kind of a perverse effect of the law, in that smoking homes have increased. The children have increased codeine, not with codeine, but there's increased smoking exposure at home because they're not going elsewhere.
Right. So.
What do you make of that explanation? Is that something you think could be viable?
Right, so that is a big concern, that people, if they can't smoke at bars or restaurants, are going to smoke more in homes, around their kids. But there's been several studies, I haven't looked at the economic studies, but there's been several, public health studies that have looked at that in Ireland, and the Scottish study that I mentioned looked at it, and they found no difference after the ban in the number of people who smoked in the home. So it was a big concern among tobacco control community, but the studies that have looked at it have found that it hasn't been the case.
Could you have, though, an increase in the number of cigarettes being smoked at home, but actually the same number of people smoking? Because it's, the way you worded it sounded like it's not.
I'm not saying prevalence would
proportion of
go up.
people. Yeah.
I'm saying the
So
dose.
basically, it could be the same number of people smoking at home.
Right.
Just maybe they're smoking their entire pack per day in the home as opposed to half at a bar and half at home.
In Santa Monica is just about to ban more smoking in apartment complexes, so that basically if someone even in your home complex is getting a cigarette smoke, then they can ban it in that area. And public health has done an amazing job at changing norms for smoking, but I just wonder how, where are we pushing these people that have perhaps a genetic, some addiction, that we're changing the structure of who's smoking, but the intensity is always a question.
My impression, and I don't know the literature very well in this area though, but I've been under the impression that there's also been a shift towards even, addicted smokers smoking outside more as opposed to inside the home as education has kind of increased. I don't know if you know the literature on that at all. Or...
I think you're right, because like you said, a lot of we're changing social norms, so smokers are more aware of the harmful impacts that it's having on their children, and so they're trying to smoke, like you said, outside, away from their kids. Yeah, and
I'm still a little concerned with what Dan was talking about in terms of the time trends. Even though you adjusted for the temporal trend, the annual temporal trend, and decreasing BMI, you said that the population, the base population was still the 2000 census. I mean, did you put, so this was a Poisson regression? Did you put population offsets in the regression?
Yeah, so each, there was a population for each town, each town had a population. That was the offset in the model. But it was all from the 2000 census. And I looked at how the population changed from 2000 to 2006, and it didn't change very much. It was kind of a steady 0.6, 0.7% increase over that time period, and there wasn't any large jumps.
No big e-migration or migration
No.
of immigrants or anything like that?
No.
Okay.
Could you go back to that Poisson time trend slide? That was interesting to ask.
Sure. Just one more comment before we jump off.
Sure.
There's something exciting that could be a concern. I mean, you do have a little bit of empirical data though that says that children that are from homes where there are smokers, the point estimates were still about 1, correct, right? Pretty close law. Is that right for clinical symptoms, clinical asthma symptoms?
I'm sorry, what?
There was no
Yeah, I
difference.
didn't see any above.
That's right. They were all about 0.97, 1, 1.0, right?
For
That's
Coatney?
not surprising
Yeah.
at all. I mean, when you do actual air monitoring inside a home where there's smokers, I mean, the exposures are just way more than you would get in just about anywhere else unless you go to a smoky bar. I mean, honestly, these kids, and they're exposed, when we do continuous air monitoring inside a home that we thought was a non-smoking home, we can see that it is a smoking home with really, really high PM concentration. And those concentrations, especially when it's cool, remain throughout the evening, all night and all morning. So these kids are not only exposed during the day, they're exposed at night when everyone's asleep, because the particles don't go away. They remain suspended for many hours. So I mean, I'm not surprised at all with that. I would expect that a smoking home would just overwhelm any kind of ban elsewhere. Because these kids are going, if they're kids, they're going to school, they're not going to be smoking at school anyway. They're not going, they may go to a restaurant, where else are they going to go? So it could affect an adult who's exposed at their workplace, but not a kid. So I'm not surprised at all. That's a logical finding.
Right, and studies have found that the home is the biggest predictor of children's coatney levels. So,
Yeah.
yeah. This graph or the-
Yeah, so I was curious about this one. You mentioned that there was this cigarette tax put in Massachusetts around 2003, was it?
Yeah, I have a figure, if you'd like to see it, that charts the cigarette consumption over time.
Right, I don't believe you that it plateaus. I was just wondering though, if you can pick that up at all in these change scores, or if that could be part of that, because you might expect if you see that decrease in cigarette consumption, and there's really a link, the AMI, that would have had some effect, right, on the time trend?
Right, so I think it was 2002.
I don't know if that's easier to see on this or on the sinusoidal trend slide, that's the raw data. But I was just wondering if you can actually see that in the AMI pattern, like any impact of the
Right.
tax.
Right.
Or if there appears to be any sort of, deceleration or acceleration of the decline.
Yeah,
in
'cause there
AMI.
was definitely a decrease in cigarette consumption.
Because you said you might expect from this that it could be, 6 to 12 months, I guess, after the
Right.
tax
Right.
gets
So,
put into place to see some kind of drop.
right. Right. I can't remember the exact month. I have it on another slide, but
I was just curious, did you think a little bit about trying to actually put that into the model at all to see if you could pick up that component of the trend? Like if there's a change in the linear trend, like a spline or something, at that
Right.
time of the tax?
yeah, no, we didn't look at that, but it would be something to look at. Yeah.
If you could actually go back to that sinusoidal slide, just one kind of follow-up question to that. I guess it kind of speaks to a larger issue of, I guess you assumed a linear decline for the trend. So, any departures from that linearity then could get kind of confounded with the
Right.
post-ban kind of estimates. So very sensitive, I guess, to any departure or change points in the linear trend that might be caused by something around, even if it's not at the exact same time. I think if there was another, like a change in the linear trend after 2003, after the cigarette tax. Though I guess if the argument is that it goes down and plateaus,
Right.
then you maybe see that trend only last for a year or so after the sales tax, so maybe you're okay.
Yeah, I mean, there are other ways to model the development of, trend and linear. There even models are good at looking at seasonality and these things.
Yeah, so I mean, it appears reasonable, just looking at the data. It's just
Yeah,
hard
it
to sense
does.
that.
Yeah, with linear, but there has been a study, I think it was conducted in Italy, that,
Mhm.
the association between smoke-free air miles and AMI hospitalizations. And yes, they looked at AMI hospitalizations, which is a little bit different than mortality, but they found, when they modeled time linearly, they found an association,
Mhm.
but when they used a spline, they didn't
Mhm.
find an association. So I think it would be interesting to use a spline with this data and see what we find.
Yeah, it will be interesting to look out past into more years, because you can see the peaks actually. The one peak that you have there in winter, there's one that still spikes up above the predicted. Then the next year,
Yeah.
it does not. I mean, I'm not saying there's anything per se in that, but if you have a smoking ban, it's especially in Massachusetts, it's very cold. I mean, it's very, very cold, and you go out or you're in any building, everything gets sealed up, and concentrations can go up quite high in the winter. So that's when you see the biggest impact. Really, is in the winter when there's low low infiltration rates.
Right. That's a good point.
Maybe it was just a lot of snow that winter, there was a lot of shoveling.
Yeah. A lot of shells.
I guess it's one of the limitations of this time trend. It's hard to really suss out.
So it's been 4-5 years since this law, and there's still some exposure. I mean, children are not down to zero, even those who don't live with smokers. Is there something in your study that could support the initiatives in California to extend the laws to outdoor public places, like parks and the beach? And I think Santa Monica had a proposal at some point to do that.
Right, I think, yeah, there have been some laws implemented in California that ban smoking at beaches and parks. So, yeah, that's kind of in the works. But we didn't find a decrease, we found no decrease in kids, and so I think it'd be helpful to look at interventions to try to, lower secondhand smoke exposure in kids by reducing the amount of smoking in the home. So, possibly, pediatricians speaking with parents who smoke and try to reduce parental smoking around kids.
Okay, thanks. We are going to walk down to Veggie Grill right now. If anyone would like to join us, you're welcome. Have your company.